Good morning, and thank you again for having us. Luke, I appreciate the opportunity to work with you guys. My name's Steve Wilder. The gentleman next to me is Dan Wilder, who, yes, he is my brother, and he's actually my son, and the heir apparent to the company, if you will. Dan and I have, and my business partner, Chris Sorensen, and a couple other guys been doing this for a lot of years now. I've worked with Michigan Healthcare Association on many occasions in the past. And it's a pleasure to work with the Region 6. We've worked with a lot of coalitions around the United States, and it's a pleasure to be with you guys today, and I thank you from the bottom of my heart. The program that we're doing today, and I'll let Dan talk more about that because he really, and I've got to be fair, and I guess it's a father's pride talking at the same time. Many of you can understand that, but this program was started back in the late 1990s. My business partner, a gentleman by the name of Chris Sorensen. Chris and I were both hospital people. I was hospital risk manager. Chris was security director. We had started our careers at the same hospital together back in the early 1980s. And when we were at the hospital together, we found that the aggression management programs that were being used were not good for healthcare, but there was nothing else on the market. Over the years, I stayed with the same healthcare system. I stayed 15 years at the hospital as their director of risk management, and then went to the corporate office as hospitals became part of bigger healthcare systems, Spent 5 years at the corporate office as director of risk and safety management over the long-term care division. Chris was at the hospital for 10 years, and then he moved on to bigger and better. We're in the suburbs of Chicago. He ended up as the chief safety officer at Christ Hospital in Oak Lawn, Illinois, a 900-bed teaching facility, and then later took the position of director of security and chief of police at the University of Chicago hospitals in the city of Chicago on the south side on Maryland Avenue, 1,200-bed nationally renowned teaching university. So even though our paths went separate ways, we still stayed together, sharing training programs, helping each other out at our respective facilities, what have you. And in late 1999, we were approached by a young lady from Brady Publishing, which was a division of Simon & Schuster. And she asked us, after seeing a little bit of our program, if we would be interested in doing a book on dealing with aggression management in healthcare. Of course, back in the late 90s, early 2000s, it was nowhere near the crisis that we're facing today. OSHA wasn't even touching the subject at that point in time, where today they're on it every single day, it seems like. I was at and I should share with you, Dan and I both are blessed with dual backgrounds. We both also have extensive careers in the fire service. I was 35 years in the fire service, 31 with my department. I'm the retired fire chief in Bradley, Illinois, and I also spent 27 years as a licensed paramedic in the state of Illinois, all of it with my fire department, although I also worked part-time on a hospital-based ambulance service as well at the time. Dan has almost 20 years, it'll be 20 years this summer. August. He'll have his 20 years in at the department as well, and continues to serve as a apparatus engineer, as an EMT, and continues to serve our community. But the conference that we were at, where we met the person from Brady Publishing, was, and I'm sure some of you, being with pre-hospital, are familiar with the Fire Department Instructors Conference that was always held in Indianapolis. And I was down there because I was training director for the department at the time, and I was down at FDIC, and that's when I met this woman from Brady Publishing, and she asked if we'd be interested in doing this book on dealing with aggression management in healthcare. And out of that was our first book, titled The Essentials of Aggression Management in Healthcare, From Talk Down to Takedown. At that conference, I also met a gentleman by the name of Chief Skip Coleman. Skip was a battalion chief with the Toledo, Ohio Fire Department at the time. And over dinner one night, Skip started talking about one of his lieutenants who had lost his career with the fire department because of an event that took place on an EMS call. And I asked him to elaborate, and he shared Jeff Cook's story with me. And I've since had the pleasure of meeting Jeff and talking to him on a number of occasions. But Jeff was working, he was assigned to an engine company in Toledo, Ohio, and at 4 o'clock in the afternoon, one day, his engine company was dispatched for an EMS assist to a single family residence in Toledo for multiple stabbing victims. When they got there, they were greeted by 2 ambulances on the scene. They had a woman who had been stabbed multiple times who was in a cardiac arrest. They had a 12-year-old girl who had been stabbed repeatedly and a 10-year-old boy who had been stabbed and slashed repeatedly. They also found the family pet had been stabbed repeatedly. Protocols at that time, I don't know what they are now, but it's irrelevant now, but at that time, protocols was that the local resource hospital would dispatch a physician to the scene in an ambulance, and that came out of St. Vincent's Hospital in Toledo, and they dispatched a physician with an ambulance to the scene, and the physician assumed medical command, overseeing care of the patients. Because they had multiple critical patients, Jeff offered to drive the ambulance to the hospital, leaving his engine company and driving the ambulance to the hospital. As they were en route to the hospital, he had one of the other ambulances in front of him driving to the hospital. He saw an individual standing on the street corner holding what looked like a stick from a distance. And as they approached the individual, as they approached that intersection, the individual raised the stick. Jeff recognized it to be a shotgun and saw the individual fire the gun at the first ambulance. That ambulance veered off the road. Jeff used his ambulance to try to strike the individual standing on the corner holding the gun, but the individual jumped in a van and took off. Jeff then jumped out of his ambulance and ran up to the driver's side door of the preceding ambulance and found the driver was laying between the seats on the front floor. He had not been shot. He had apparently seen the shot coming. So Jeff then ran around to the passenger side to be of more help to the individual in the front cab of the ambulance. And when he got around to the passenger side, the same individual who he saw drive off with the van was standing there with the shotgun. And Jeff said at that point he was about 12 to 14 feet away from him. And he said the individual raised the shotgun and pointed at him. And Jeff said, you hear in the movies that this stuff plays out in slow motion. He said, I remember the smirk on his face. And he said, it was like it played out in slow motion. He said, I remember seeing him pull the trigger and I saw a muzzle flash from the shotgun. And then he said, I just felt the most incredible pain I've ever felt in my left arm. Well, Jeff was shot in the left humerus at close range by a 12-gauge shotgun. The blast crushed his humerus, penetrated into his chest, and he also took pellets in the chest and in the rib cage area, as well as penetrating into his lungs. The physician pronounced the woman dead at the scene and turned his attention to Jeff, who was immediately transported to the hospital. The individual, by the way, then carjacked a vehicle, drug a woman out of the car, carjacked the individual's car, and went on a terror ride through downtown Toledo, chased by the police until he pulled into the parking lot of an empty shopping center where he engaged in gunfire with the police and was shot and killed by Toledo PD. Jeff was taken to the hospital. By the time he reached the hospital, he was comatose. He was taken into immediate surgery. He pretty much lost the entire use of his left arm, partial loss of a lobe in the left lung, permanent damage. He was in a coma for 2 days and never was able to return to his job with the fire department in the capacity that he loved, which was working as an engine company officer and working as a training officer. Ended up being assigned as a supervisor on the midnight shift in the dispatch center, which it wasn't for him. I can understand that. But in the end, it ended up costing him his career with the fire department. And I share that story because I know many of you are involved in EMS. And my homework assignment to you before I turn it over to Dan here is I'm asking you to please remember your EMS providers when you're looking at your workplace violence prevention program. I don't care if it's a hospital-based ambulance, if it's a privately owned ambulance, if it's a fire department EMS service. Remember those providers. They're in the back of basically what turns out to be a 4-foot wide by 8-foot long box, and oftentimes one-on-one trying to deal with a combative subject. We need to make sure that they get the proper training to be able to de-escalate and control the aggression of that individual, as well as our staff that's in the ED and the behavioral health units and everywhere else in the hospital. So Jeff is retired now. He is living, he's on a disability pension. It's been a couple of years since I talked to him. Last time I talked to him, he was living in Kentucky, and he is married to a woman who is a nurse down there. And he's put his life back together, but it's still, at the end of the day, it took away his career. And any of us who, there's two type of people that work in the fire service and EMS: those who see it as a job and those who are in love with it. I was one of the guys that was in love with it. And I think Jeff was too. So it took away something pretty special. So thanks for letting me share Jeff's story. Thanks for taking the homework assignment. I'll turn it over to Dan, and he can take it from here, and I'll be joining you again in a few minutes.
All right. Well, thank you, Steve. We're going to begin. And before we get started, I really want you guys to start thinking about some of these scenarios. We're going to go over a few different slides here of some what would you do if scenarios. And how would you handle it if you were in this scenario? First one, an employee entering the facility carrying a brown paper bag. The employee doesn't say anything to anyone and is wearing camouflage clothing. The employee has been acting strange for the past few weeks, making threats to his supervisors and fellow employees, and making comments about getting even. Where are our warning signs? Do we see things here that might tell us there's something wrong? Is it normal for this person to wear camouflage clothing? What were the threats that he was making to his employees and supervisors? And how are we going to handle this now that we see him in here with the camouflage clothing and the paper bag? Are we going to confront him and ask him what's in the bag, knowing that it's a good possibility maybe it's just his lunch? Do we have that comfort to talk to the person? How about a coworker comes in and tells you he or she is going to commit suicide? We know that people that are going to commit suicide will usually reach out for help. And if we see this and we just think, oh, you're just having a bad day, get over it, let's go, come on. It's kind of justifying it for them. And how do we respond? Do we know where to go? Are there EAP programs involved? Coworker comes into the nurse's lounge while you're in there and says, I've had it with that blankety blank, and if she doesn't watch out, she's going to be one sorry short of breath. Again, is this just somebody blowing off steam? Or is this somebody who is really making a threat? We've all had bad days. We've all been in this scenario. How about a patient seeming anxious and confused? He is asking for his medication and making statements about this blanking hospital and this stupid staff. Is he venting? Is he blowing off steam? How are we going to respond? How are we going to get this person to calm down and bring him back to a level of calm? How about a female coworker going through a divorce, gets a call from her estranged spouse, hangs up the phone and says he's coming here to kill me? Do we know how to lock down our buildings? How quickly it's going to take, or how long it's going to take? Who are we going to call? Do we have a security department we can notify? Are we relying on law enforcement? And what's their ETA if we have to call 911? Or when your partner arrives to shift with a detectable odor of alcohol in his breath. This happened at one of our neighboring fire departments, where a guy going through a hard time had an incident where he was using alcohol to help get him through the day. His lieutenant was a good friend of his and went through fire academy with him, and would try to cover for him by sending him home and telling him to go get help and get over it. But at the end, the lieutenant had to do what was right, and his friend lost his job. Are you prepared to do that? Are you prepared to cover for your friend, or are you prepared to report them, knowing that they're going through a hard time? So, a family member of a resident comes into the facility, obviously intoxicated, and says they're taking mom out of this blank hole. Again, do they have the right to take mom out? Are we able to stop them because of the fact that they're intoxicated? And how are we going to do that? Psychiatric female patient is causing problems in a group with other patients. You attempt to remove her from the situation, and she says she threatens to attack you. How can we talk to her to bring her back down to a level of calm? Each one of these scenarios creates a moral dilemma and could lead us into workplace violence. Do you cover for your friend that you know is going through a hard time? You know that if you turn them in, they're likely going to get fired or at least have a more difficult time. Do you encourage them to seek help and go home? Do you get them out of work activities and contact the supervisor? Or do you contact the supervisor and document the incident? Each one of these could lead us into workplace violence if we're not careful. So at the conclusion of today's program, we're going to discuss, or you're going to be able to discuss, the impact of workplace violence. You're going to be able to discuss the role of de-escalation in management of disruptive and aggressive behavior, describe the purpose and acceptable use of self-defense maneuvers taught in class, when I'm doing this in person, I always ask the question, how many people have been victims of workplace violence? I usually get about half the hands raised, and then we go through the definition, and most of the other hands go up. In simplest terms, any incident in which an employee or employer is threatened, intimidated, physically or verbally attacked, harassed, injured, or killed has been victim of workplace violence. So ask yourself, in the course of a day, have you been threatened at work? Have you been intimidated or verbally attacked? At some places, that may happen just about as soon as you walk in. If you're working in an ED, that could happen pretty quick after starting your shift. But if you've been with any of these, if you've had this happen to you, if you've been attacked or cussed out or physically threatened, you have been the victim of workplace violence. I'm not going to spend a lot of time looking at stats, but there are some that we need to talk about because I feel like we don't draw enough attention to these. And if we were to put more emphasis on reporting and tracking and identifying the workplace violence as it happens, there'd be a lot more cases, and maybe we'd be able to get some better answers. But according to OSHA, about 75% of the nearly 25,000 workplace assaults reported occur in the healthcare and social service settings. Workers in the healthcare settings are 4 times more likely to be victimized than those in the private sector. And everybody here today is in the healthcare setting, whether it's pre-hospital or post-hospital care. The National Crime Victimization Survey shows workers in the healthcare settings are at a 20% higher risk of experiencing workplace violence than in other settings. And again, I think that's a little bit low, but I think a lot of our incidents go unreported because we just view it as part of the job. The Joint Commission Sentinel events data shows 68 incidences of homicide, rape, or assault of hospital staff members over an 8-year period. And again, I think that number is also underreported. On average, over 400 serious violent-related injuries among EMS personnel occur every year. My department specifically, we just had a lieutenant who had to, a captain who had to retire from an injury that he had almost 20 years ago. He had an ACL tear, a rotator cuff tear in his shoulder due to a patient becoming combative, and it never healed properly, and he just injured it again about a year ago, and they weren't able to repair it enough for him to come back to work. So this ended his career as well. Violence is most common in psychiatric facilities and ED departments. That's not new for anybody who's here in this presentation. Nurses are the most frequent targets of healthcare and violence. Half of ED nurses reported experience violent patients on the job. I think the other half just haven't reported it. 1 in 4 nurses experienced 20 or more violent incidents in the past 3 years. And again, I'm going to go with saying that's underreported.
Dan, I'm going to echo what you said a minute ago, though. So many people don't report it because they think it goes with the job. And I think it really is worthy of emphasizing to everybody that being the victim of workplace violence is not part of your job. I don't care what your role is as a caregiver, administrative, it doesn't matter. Nobody is expected to just take it. So please realize when we're looking at these incidents, and Dan, I think you'll agree with me on this from our past conversations, you don't have to go to work thinking that you're going to have to take this. You don't have to take this. And it's one of the reasons that OSHA's gotten so involved with this as well, because for a long time, healthcare organizations, whether it's hospital, long-term care, pre-hospital, whatever the case may be, we're doing nothing about it. And OSHA is forcing the issue now with healthcare providers and forcing them to do something about it or face major financial penalties if they don't. So,
thank you, Steve. So, over the next couple hours, we're going to talk about ways that we can avoid or minimize workplace violence. And one thing we hear a lot when we're discussing workplace violence, whether it's at my firehouse or the neighboring firehouses or departments that we go and provide training for, or hospitals that we're doing the training for, is they all say the same thing. 1 minute we're in a conversation with the person, the next minute they're growing lumps on my head. Incidents of workplace violence can almost be predicted if we know what to look for. We're going to talk about a lot of different ways of dealing with aggressive individuals. There is no 100% surefire way, but if we understand what to do and we understand the issues, we can almost predict when it's going to come. Like any of our other plans and programs and trainings that we have, workplace violence in the healthcare organization is just another page in our emergency response manual. If we know what to look for and we recognize it, we can either avoid it or mitigate it through preparation, but we have to train on it. We can't see this presentation today and think, okay, I'm an expert at de-escalation. As Steve said, we've been teaching this program for a long time. I've been doing it for almost 20 years. And there are still people that I cannot talk down. There are still times when I get tongue-tied or say the wrong thing when I'm trying to de-escalate the person. But through practice and through preparedness, if we do have to put this person in restraints, or we do have to go hands-on with the person, we can mitigate the outcome. And we can make sure that there are no injuries, or at least limit the injuries. So to increase our safety, follow these simple guidelines. First off, limit physical interventions. When I was 18 years old and got on the fire service, it was fun to be in the back of an ambulance when a person was getting aggressive or combative. 20 years later, 2 back surgeries later, it's not as much fun. And I'm much more likely to spend a long time dealing with the person before I put hands on with them. And if I can talk that person into cooperating, I feel like I did my job better, because now I'm able to make sure that I didn't get hurt, none of the other people that are dressed like me got hurt, and our patient didn't get hurt. Use an adequate number of staff. We've been in scenarios where there are so many people involved that we can't count. We don't know where the patient is and where the staff are. When I was very new in the career and I was going through college, I was working for a dispatcher at an ambulance based out of a hospital. And one night we heard the Dr. Strong code, and that was a code for an aggressive person in the 4 West department, which was our med surg department. Our policy said every person who is not busy, respond. We've never been trained. We were never talked about how to respond to this person, but our protocol said that if you're in the hospital and you're not otherwise tied up, you respond. And so myself and another gentleman went to the scene, or we responded to it, and we got there, and there was about 25 other staff members who also responded. And I can only imagine it looked like the beginning scenes of Jurassic Park when you see the T-Rex running and the water shaking in the desk, because there were so many people running down the hallway for a elderly old man who was just getting a little bit aggressive because he didn't understand why he couldn't leave. They were able to de-escalate the person without a problem, and there was so much testosterone in the air that I thought there was going to become a boxing match of the people who responded, just to burn off some of that energy that they got running to them. Develop and train an emergency response team. This team will be specially trained with the ability to respond for emergencies. They have extra training in de-escalation and advanced control skills if necessary. Importantly, provide training to all employees. This program, or any workplace violence program, can be beneficial to every single person in your building. Whether it's a person in registration or a person sitting at the desk, we deal with aggressive people, we deal with aggravated people, and knowing how to talk to them can help them bring them back down to a level of calm. Steve?
You know, that is such a great point, Dan, because we see so many providers now who are focusing their attention on training the nursing staff, training the ED techs, behavioral health techs, those folks, and boy, I sure don't want to play down the criticality of that at all. But think about those other folks too. And Dan mentioned specifically the registration folks, and think about what those people sometimes go through. Think about the ED patient registration area. Patient comes in, they're critical, semi-critical, they're taken right back to the ED. And what do we tell the family? Go over and make out a chart. So we send them over and we're asking them all these questions about payment and about registration information and about insurance information, copay and everything else. And they're not thinking anything about that. All they're thinking about is mom's back there, she's critical, I want to be with her. And so they start they're frustrated, they're not angry at that registration clerk, but they start venting their frustration at that person simply because they don't like the way the system operates. So they end up taking their frustration out on that person. How that person responds may dictate what that family member's next step is. If that registration person is trained to de-escalate, as Dan and I will talk about later in the morning, if they're trained to properly verbally de-escalate, we should be able to get them through it. But if they're not, and they handle it inappropriately, they may agitate that already worked up family member to the point that the situation intensifies and it didn't need to. So I think that's a great point, Dan. I appreciate you bringing that one up.
Thank you. Train your employees using role-playing situation and mock drills. Role-playing, just simply doing some what-if scenarios. Whether you're sitting in the firehouse or the ambulance bay one night on a quiet night playing what-if scenarios, or if you're doing mock drills. That's a great way for employees to retain what they have already been learned and make sure that it stays fresh in their mind. But keep these drills realistic. We've all been in different trainings where it seems like they're trying to trick us into failure to make themselves look better, and that's not the goal here. We want success to be the absolute outcome. So let's make these realistic and let's not throw in so many curveballs that it confuses people. We're going to look at some characteristics of the potentially violent person. These are characteristics of people on a national level. So they may be a little bit different in your area, but keep this in mind. 80% probability that the person will be a male. There's something about the male ego, if you will, that may go into violence a lot quicker. 75% chance that the person will be Caucasian. Now, this one might be a little bit different in your area based on the ethnic background and multicultural diversity that you have in your area, so it may change. And then 90% of the probability that they'll be of working age, 16 to about 65. When you see these characteristics, you're going to start to think about people. And you're going to think, oh, that's so-and-so. Try not to do that. That's not fair to them. First off, pathological blaming. That person that can never take responsibility for their actions. They did something because you pushed them. It could have been avoided, but you did this. Think about all the shootings and all the different acts of violence that we've heard lately. There's always somebody else being blamed. It's never somebody taking responsibility for their actions. They were pushed to this because of whatever the case may be. A person with a history of depression. In the early days when depression was first getting recognized, people heard of that and they just backed away and they didn't want to talk to you because they were afraid that they were going to catch depression. We now know that that's not really the case, but it can be managed as long as that person remains on their meds. And the concern comes when that person comes off their medication and they stop taking their medication, they start feeling bad again, they start getting these ideas again, and we get in the way of their decision, or they begin to make a plan that we're not ready to deal with. Person with a personality disorder. These people may go from calm to violent quickly and without a lot of warning, and we may miss the signs because we don't see them and they don't process the information the same way that we do. Person with a history of violence. Keep in mind, if they've been violent before, there is a good chance that they'll be violent again. And we need to track this. If there is a history of violence with somebody, especially if it's somebody in the hospital or that we've dealt with in the past, we need to keep a note of that. A lot of our reporting softwares will track it, but what if they haven't come into your building before? Is there a way to get an advanced warning before they come in or before they bring in a family member? The simple answer is yes. Give me 1 second here and then you can jump in. Each morning that I work at the firehouse, I like to get up early, and on Saturdays the newspaper is delivered and it's on the porch, and I get my coffee. And on nice days, which in Illinois, much like Michigan, we don't have a lot of those right now, but on nice mornings, I'll sit outside and I'll drink my coffee and I'll read the paper. And one of my favorite areas is reading the blotter and the arrest records for the week. Anytime I see somebody who's been arrested for a violent crime, regardless of what it is, if violence was used in it, I'm cutting that out and I'm placing it on our bulletin board. Because now if we go at 2 o'clock in the morning to Mr. Smith's house, we know that last week he was arrested for spousal abuse. So we're not going to treat him or his family any different, but we're going to go in there with a higher sense of awareness and keep an eye on what's going on, because we know that in the past, Mr. Smith has been violent. Steve, did you have something you wanted to add?
Yeah, it brought back a memory of when we did a security vulnerability assessment a number of years ago at a hospital, and I think it was in the Milwaukee area, but it doesn't matter. And I remember they used Marshfield, okay. They used a code purple as their overhead paging system, which I'll probably end up at some point in the morning sharing my feelings about color codes and coded messages, but for now I'll bite my tongue. But they used the code purple, they had done something really neat with their electronic record system. If they ever called the code purple on that patient, with the click of a mouse on that screen, there was a little box they'd click, and it would automatically put this cute little purple border around the screen. Nobody knew what it meant. Hopefully nobody outside was seeing the screen anyway, but all of the staff were trained as part of new employee orientation that if you see the purple border around the screen, that means at some point, either on this admission or past visit, we've called a code purple on this person. Again, as Dan said, you didn't treat them any differently, but you went in there with a heightened sense of awareness, because as Dan said, if they've got a past history of violence, it's not a one and done type of thing. You know, think of spousal abuse and all that. If it's happened once, it's going to happen again. Very rarely is that not the case. So, you know, look for ways that you can communicate amongst each other. I've had people, Joint Commission won't allow that. Yes, they will. And we've got plenty of resources at Joint Commission that every time somebody says Joint Commission won't allow it, we've got phone numbers of people we call and talk to at Joint Commission. Same with DMV and everybody else. So yeah, it is allowed. It's a great way to communicate to one another on different shifts, different admissions, maybe 3 months later, 6 months later, that at some point in the past, this person became violent, had to have a code purple called. So, you know, just something to kick around, think about, and look at what your IT systems are capable of doing for you.
Evidences of erotomania, or simply somebody who just finds violence as a way to get what they want, a way of justifying a means to an end. I'll never forget after 9/11, growing up at a firehouse and going there after the first plane struck the tower. We were sitting in the department or sitting in the day room, and it's the first time in my entire life that I've seen that place quiet. And everybody's watching it, and we know that we know just the craziness that's going on, and it gets to the point where the second tower falls, and one of our new guys sitting there in the department looks up and he goes, "Well, I wonder if New York is hiring now." And he didn't see anything wrong with what was going on. He saw this as a way for him to get on New York's department. That quiet department did not stay quiet for very long, and he was pretty much chased out of the building, never came back, never showed his face there again, dropped off his belongings or his department issued belongings in the middle of the night, left him on the doorstep, never saw the kid again, and I couldn't even remember his name, but what he said that day, I always think about it when I get to this point, because he didn't see anything wrong with the violence that was unfolding, and the fact that 300 of our brothers died. It was cool. There's 343 job openings at New York department. I can go get hired. An interest in weapons. Interest in weapons alone does not make somebody violent. I know a number of people, a few of us in this room, who own a firearm. I'm willing to bet there's a few of you out there that own a firearm, but that doesn't make you a violent person. Where we need to be concerned about is when it's an unhealthy interest in weapons, and we're focusing on what the damage can do and how many people it can hurt. That's when we need to start worrying about the person carrying the weapon, not the fact that they simply own a few firearms. For time purposes, I always put these two together, and that's chemical and alcohol dependency. Again, not worried about the full-blown alcoholic or the full-blown drug addict. I'm worried about the weekend warrior, if you will. The person who is experimenting with drugs for the first time, or the person who just drinks a little bit on the weekends and then goes through some emotional changes. Those kind of people are the ones that concern me the most. Especially right now, where you have some states are legalizing marijuana and other states are not, and people going into these areas for vacation or business or whatever, and they decide that they want to try it after not having it for many years. We do a lot of work in Colorado, and they have seen a huge increase in the number of aggressive people who are coming into the hospital with marijuana overdoses, and they're hallucinating, and they're not seeing things and processing the right way. And up until I started working in the Colorado area, I didn't even know you could overdose on marijuana. But what's happening is they will take an edible or part of an edible, wait about 15 minutes, not feel anything, so they'll eat the rest of it, not feel anything, eat another one, still not feel anything, so then smoke a joint, and all of a sudden it all hits them all at once, and now there's a large amount of THC going through their body, and they can't process it. Steve, did you have something you wanted to add? You look like you wanted to say something.
Well, in the marijuanas that are out there now, and you know, I'm a child of the 70s, and it was ditchweed back then, but the stuff that's out there now is so synthetic, you don't know what's added to it. So, you know, Dan's right, you know, people look at it and say, hey, you can't overdose on marijuana. Well, the effects that it has on these people now as they play with some of the synthetic stuff is close enough that I don't have a problem with calling it an overdose either.
Elevated frustration levels. Sorry, my tongue got ahead of my mouth there for a minute. We're in a time that's very frustrating for all of us. It's, you know, good people are being forced to make decisions that 2 years ago they never would have had to make. And we all know that people under high level of stress make decisions that we normally wouldn't do. Impaired neural functions. People coming in or being taken in on the ambulance that have had head injuries, bad injuries from a crash. Okay. These people may not be processing information. They may be, their fight or flight may have kicked in. And then evidence of psychosis, again, somebody who may become violent quickly without a lot of advanced warning. So keys to prevention. Connect with this person during a calm, non-threatening time. Try to build some rapport with them. Now, if you're working on the ambulance or in the ED, you may not get a lot of time. They come in, there's an emergency, we try to help them out as quickly as possible. But if you're on the floor, if you're in a psychiatric facility, we may be able to connect to them during a non-threatening time and start building some rapport with them. As soon as they enter the facility, and that's why this training is so important, the first person to contact, treating them in a kind, caring, empathetic manner has a better chance of keeping this person calm than the person who comes in and what do you want? Why are you here? If they don't feel like they're important, they're going to do something to make themselves important. Okay? And as I said, conduct every interaction in a kind, caring, empathetic manner. Ask yourself, how can I best help this person? And remember one of the most important things, if it feels good, don't say it. And I always joke, when I retire and I'm sitting on a beach somewhere, I'm going to write a book. And the book's going to be all the fights that I've started with my wife because I had to have the last word. And it's going to be called What I Should Have Said Was Nothing. Because sometimes you speak in anger. And it is impossible to take back those words once you say it. And it may feel really good to say it when you're dealing with a difficult patient. But words spoken out of frustration really cannot be taken back. So, elements of building a positive rapport. The person has to trust you. If they can't trust you, they're not going to listen to you. They're not going to believe what you say, and they're going to second guess everything that they're told. You got to have a personal value of yourself, and you got to be able to respect that person. And most importantly, at least in my book, you have to be honest. You have one chance to make a first impression. And if you're not honest with them and you lie to them, you're not going to have the rest of them. You're not going to have their respect. You're not going to have their trust. Everything builds off of honesty. We're going to talk today about some different scenarios where people that I've worked with have been dishonest to our patients, and what are the outcomes. So the first one is trust. We had one of our former instructors helped us with this, and they said trust equals consistency plus predictability over time. If you're consistent and predictable, eventually they're going to have that trust. And it kind of rang true for me a few years ago. I have a 20-year-old son, and since he's been growing up, we've always told him, when we tell you to be home at this time, it's this time. If you are late, even by a minute, 12 o'clock is 12 o'clock. If you're late, there will be repercussions. And when he was growing up, he would, like most other boys, he'd like to ride around on his bike and ride through the neighborhoods. And his mom, growing up in the country, wasn't real comfortable with her riding around town. And said, it's fine. It's the same neighborhoods I rode around in when I was a kid. It's a safe neighborhood. He's fine. But she insisted on him checking in. So we gave him a cell phone, and we would tell him come back and check in at lunchtime, grab some lunch, and then you can go back out again. And he knew that meant he had to be home at noon. And if he wasn't home at noon, if he got home at 12:01 or 12:05 or any later than 12 o'clock, he had some kind of a repercussion. Usually it was the loss of his cell phone and not being able to go back out again. Well, jump ahead a few years to when he's about 17 years old, and we're meeting at my sister's house for Thanksgiving. And his best friend lives in the same neighborhood. And he said, we're not doing anything here right now. Can I run over and play basketball over at, I can't remember the kid's name, Elijah's house? I said, absolutely, go have fun. I said, we're going to eat about 5 o'clock, be home around 5. So he hops on his bike, or he runs over there, and he's gone. And about 4:30, my sister says, should we call back Bailey and tell him it's about dinner time? I said, nope, we told him to be home by 5. It'll be ready, and he'll be home. And at about 4:58, he comes barreling through the door, sweaty and out of breath, and he says, I'm here. And my sister laughed. She said, why are you so sweaty and out of breath? He said, well, I just sprinted 3 blocks to make sure I was home by 5. She said, well, you know, you could have been here at 5:05. It's not that big of a deal. And he said, no. He said, 5 o'clock is 5 o'clock. And I want to be able to go back out afterwards. And if I'm late, then I'm not going to be able to. So he was able to trust what would happen because of all the times that we have told him 5 o'clock is 5 o'clock. He was predicting what we were because we were consistent. We earned his trust based off consistency. A situation could go bad from bad to worse if we're not honest. Be honest in all situations. Explain the procedures and think of long-term consequences. A number of years ago, we had a call for a 16-year-old kid off of his medication, laying in the middle of a busy road, waiting to get ran over. We get paged out on the ambulance, and I'm working that night, but I was working on the engine. And the paramedic in charge said, hey, can you just come and bring your engine and, you know, just kind of block the road so nothing happens? And we said, absolutely. So we get there, we block off the road and make sure nobody can come out. And then the crew hops out just in case anything can go wrong, because we can hear him yelling at the cops and yelling at his mom before we even pull up. We get out and we walk up to the scene, I guess, and the kid is yelling at our paramedic and making threats to him. So I went and got the restraints, and I'm ready to put him on him because of the way he's behaving. He's probably going to get put into restraints. And after a couple of minutes, the paramedic said, what is the issue? Why don't you want to go to the hospital? And he said, last time I was there, they kept me there for 3 days. They wouldn't let me have any of my clothes. They wouldn't let me have my phone. They wouldn't let me have anything. I don't want that to happen again. And the paramedic looked him in the eye and he said, if that's all you're worried about, do me a favor, get on the cot with me. I'm going to call the hospital and let them know that you're cooperative and that you don't want to be there for 3 days. You cooperate with us on the way in, cooperate with the nurses. They're going to check your blood levels. That'll take about 10 minutes. And you'll probably be out of there before I am. They just want to make sure that they get you on the right meds again so you don't have this happen again. He said, really, I'll be out of there that fast? He goes, I promise you'll be out before I am. Everybody in that area knew that he was lying. But the kid believed him, got on the cot. They drove in without any incident. Gets back to the station and he's all smug and smiling. He said, what do you think of that talk down? And I said, well, I think you lied to him and the hospital is going to have a hard time with him over the next few days. They said, yeah, but I got him in the ambulance. I said, right, you got him in the ambulance, but you did so under false pretenses. You lied to this poor kid. So this kid's having a hard enough time without having the people that are there to protect him lying to him. But I got him in the ambulance. He didn't see anything wrong with what he did. So what happens when we deal with him next time? Is he going to believe us when we say that we need to get him in the ambulance and we're going to take care of him? No, we lost his trust. He's not going to be cooperative for the people at the hospital either, and the facilities that he goes to next. He's going to be giving them a hard time also. So we need to think about those long-term consequences and the problems with lying to a person. Respect is a challenging one, especially when the people are yelling and cussing at us. We still have to offer them the same level of respect. Ask yourself, how would I want my family member in this situation? How would I want my loved ones treated? That's that golden rule, treat others the way you should be treated. How are you going to respond in the same manner? At times you may need to take a break. It's possible for us to get aggravated. We may need to get out of the way. Let somebody else talk to him for a few minutes while we go into another room and vent. If you're going to discuss your challenges with another member, do it in an area outside of ear range. Okay? We don't want other patients to hear it either. Remember, don't take this situation personally. They're having a hard time on their own. Right? They didn't come to us because they're having such a great day and they decided they wanted to come and make our day harder. They're having a hard time and they needed our help. And check your biases at the door. Personal face and professional face is something we've added within the last couple of years. I'm not even sure if Steve's had a chance to hear it yet, but it's a way that we can kind of keep ourselves away from some of the stress and the burden and separate it. When we think about professional face, that's who we are when we're working. The patients that we interact with, they're interacting with the professional us. The personal face is who we are when we're home, when we punch out at the end of the shift. Our relationship with our family, with our friends, that's our personal face. We want to try to keep the two faces separate so we don't bring home all the ugly that we see, because regardless of what our actual occupation is, we see a lot of ugly in the healthcare industry. We've talked to a couple of nurses about the same thing, and one of them said that in order for her to keep her faces separate, at the end of each shift, she takes a Lysol rag and she wipes down her name tag. She said every day she's yelled at, she's cussed at, she's screamed at. She has all of that hostility going to that name tag. It's not going to her, it's being absorbed by the name tag, because that's where her professional face lives. It's all absorbed there, and she takes off that, at the end of the night, she takes it off, she wipes it off with a rag, and she puts it in her locker until the next day. The next day when she comes back, the Lysol has cleaned it off, all of the ugly is gone. A good buddy of mine helped teach this program for a while before he retired and moved out to Florida. Used to change out of his uniform. He was a retired police officer, and he said when he went home, he'd go into his locker, he would take off his uniform, he'd ball them up, throw it into a bag, and he'd put on his street clothes. By taking off his uniform, by leaving his duty belt behind and locking it in his locker along with his radio, all of his personal stuff or his professional stuff is left there at the police station. When he left as Glenn Nixon, not as Officer Nixon or Sergeant Nixon. He would take it home, he would wash it, he'd press it, he'd get it ready for work. He would come into the station in his street clothes, he'd take off his street clothes, he'd fold them up, he'd put them back in the bottom of his locker, he'd put on his uniform, changing from personal Glenn to Sergeant Nixon. And it helped him. And during COVID, when stress and things got high for me, and I was having a really hard time going into work, he talked to me about it. And he recommended that I do the same thing. He said, not only does it keep all the germs and ickiness away, but your family doesn't see you going in as a firefighter and a paramedic where they have to worry about you. And you don't see it when you come home. You leave all that stuff there. And we're lucky because we have our own washing machine and all that, so we can wash our clothes at the end of shift. We can fold them up and get them all ready to go before our next shift, so we don't even have to bring the dirty ones home. So find a way to keep your two faces separate, and it'll help you really in the long run with dealing with some of the ugly that we see on a day-to-day basis. All right, Luke, as we are coming back together, are there any questions in the Q&A that we can answer right now for him?
Yes, there is a question from Anthony C. that says, should we look at the leadership or higher management of departments or agency for not providing the support for this type of training?
This is Steve. I'll speak on that one. And in a word, I will say absolutely. The organization bears the responsibility to provide a safe work environment for all of their workers. And that's not Steve Wilder's or Sorensen Wilder's rules, that's OSHA's rules. OSHA has a document that's called Guideline 3148, which is the guideline for the prevention of workplace violence for healthcare and social service workers. And in there is about a dozen bullet points of programmatic items that OSHA wants to see every healthcare organization, and again, I include pre-hospital in that they want to see in a good workplace violence prevention program. Now, people will tell me that OSHA guidelines are not enforceable. It's not a codified standard, and they are absolutely correct. But as my colleagues in safety management arena and risk management know, OSHA uses Section 5A1 of the General Duty Clause to enforce guidelines. So I have seen many hospitals who have received OSHA citations, and right now they're averaging about $13,600 per citation, which is OSHA's typical citation amount now with the new standards out. But yeah, OSHA clearly says you've got to provide a safe workplace for your employees. And it goes back to what I said at the beginning, Luke. Getting beat up at work, taking the abuse at work is not part of the job. There is nowhere in this country that anybody can expect you to take that kind of physical or mental abuse in the workplace. So it is definitely the responsibility of the organization. If you are an employee of an organization that won't pay attention to it, you have the legal right with whistleblower protection to call the OSHA 800 number and tell them, you know, we're getting beat up at work. We're dealing with a lot of violence and our facility is not doing anything about it and refuse to listen to us. They'll show up and they'll get their attention.
And a question from Shelley, I believe it's Mao, asks, can you share where you found the stats on male, Caucasian, depression, etc.? I haven't heard of these stats before. Thank you.
Yeah, those were Bureau of Labor Statistics, and I can't give you an exact citing because we've been using them for a while, but they were Bureau of Labor Statistics. So you can go on their website, and they may be updated, and I'll need to look at them too, to be honest with you. But that's where they originated, was from BLS, Bureau of Labor Statistics.
And, oh, hold on, a couple more questions came up. Stand by. And a question came up, could you apply some of this to an adult foster care home setting that is being used increasingly for mentally ill residents that also have recipient rights, mental health code, and physical intervention can only be deployed if imminent threat?
Yeah, and we've worked with a lot of these types of homes, and not only the foster care, but the orphanage situations and some of the special needs homes. And this is a tough way to answer it, Luke, but I'm going to be very candid with the person and the folks that are asking on that regard. The imminent threat is your saving grace. Imminent threat doesn't necessarily have to mean imminent threat to themselves. It can also be to the caregivers or the providers who are responsible for taking care of them. So it almost becomes, and this is the risk manager in me, it becomes a documentation issue as well. You know, we're aware of these regulations, and the statutes and the codes vary from community to community. How do you say that?
Communities and communities.
State to state. But at the end of the day, we don't see a lot of places that are being cited for violation of that. But it goes back to you're making the decisions that are right for the person that you're caring for, and you're not doing it to punish them. You're doing it to prevent imminent injury to themselves or to you and the other caregivers.
And Don Vanderkoy writes, tips on how to de-escalate the person that will always just want to argue.
Some people would say a divorce. No, I'm just kidding. Please, I'm just kidding. You know, we're going to kind of talk about that in a few minutes as we go into the next section, and we talk about techniques of verbal de-escalation and recognizing changes in aggression. So we'll talk about that here in a few.
All right, and I have received a couple questions about the PowerPoint. Yes, the PowerPoint was shared. There was a link that was automatically sent out to this group, but if you cannot access that, please send me an email and I will send it out after this presentation has concluded. I will put my email in the chat. And Steve, it's all yours.
Thank you. And I hope everybody enjoyed the break. We're going to shift gears here a little bit. You know, Dan talked about a lot of the things that lead up to this next part of the program. And this is really what I call the meat and potatoes of the program. And before we start, somebody inevitably will ask the question, and it's a very legitimate question, friends. What qualifies you to talk about this? Well, By way of background, as I introduce myself, I'm a healthcare risk manager, I'm a safety professional, I'm a board certified healthcare safety professional, but I'm not a mental health provider, I'm not a mental health professional. When Chris, and I say Chris, I mean my business partner, Chris Sorensen, when Chris and I first put this program together in its initial phases years ago, we worked with a gentleman who was a close friend, personal friend, and a colleague of ours by the name of Dr. John Moran. Dr. Moran, at that point in his career, was working with what was then known as the Illinois Department of Mental Health, and worked with a lot of the state mental health agencies, where he was responsible for security administration in the mental health agencies, and would provide training using his background in mental health, would provide training to his to the security officers and security departments of these facilities in dealing with aggressive behavior. Dr. Moran developed all of this material, and when he retired years ago, he passed away a year ago, sadly, but when Dr. Moran retired about a year ago, he gave us, well, when we wrote the book initially, he gave us full rights for a lifetime to use all of this information of his that he had used and developed, and we've updated it since then and worked with others in the industry to update it and keep it current. But, you know, I can't say enough about John Moran, my friend, my mentor, our friend, our mentor, our colleague, and just an incredible human being who we owe so much to. Dan said at the beginning that, you know, people typically, and he talked about in the presentation, people don't typically go from a state of calm to a state of physically violent in one giant step. More often than not, they go through a number of behavioral changes. And unfortunately, we as healthcare professionals don't always recognize those changes until it's too late. And I can't tell you how many times in my career, both in healthcare facilities and in EMS, I've had somebody say to me, gosh, Steve, I don't know what happened. One minute he was fine, the next minute he was growing lumps on my head. Well, no, probably that's not what happened. What probably happened is he was exhibiting these changes in behaviors that we look for, and you've never been trained to recognize them. So that's where we're going now. We're going to look at the aggression continuum. We're going to look at the 6 steps in behavioral changes between calm and physically violent. We're going to look at Dr. Moran's work. You know, we always use a 6-foot step ladder as a visual aid for this. We've got them in our garages at home. We can picture them in our head anytime. We see them all over the hospital. We see them all over the facilities. And we can picture that step ladder without even giving it any conscious thought. On a 6-foot step ladder, each rung represents a change in behavior by the individual who's acting out. And just like when we climb the rung, you know, think about standing on that rung. When I'm standing on that bottom step, I've got all of those other rungs I can lean into. I've got the side rails I can hold on to. I have plenty of resources right there available to me to steady myself and to balance myself and to keep myself safe. The higher I go on that ladder, though, the more precarious that becomes. I start getting up around that 4th and 5th rung, I all of a sudden don't have the rest of that ladder to lean into. I don't have the side rails at my shoulder height for me to hold on to any longer. I'm kind of off balance and teeter-tottering a little bit and hoping I'm not going to fall. All of a sudden, I'm at that top step. And remember that top step of that 6-foot step ladder? You've seen it at home, you've seen it at work. It's got that big sticker on the top that says, hey, dummy, don't stand here. You're going to fall and get hurt. We have to be careful because that's where the danger's at. And no different than dealing with this aggressive person. You know, everybody says 1 minute he was calm, meaning he's on the bottom rung, and the next minute he's growing lumps on my head, which means he's on the top step up there where that sticker's at. How did he get there in one giant step? It's pretty unheard of, and that's where Dan was leading earlier. You know, we call that bottom rung on the ladder, as I just said a minute ago, we call that calm. The nice news is that's where 99% of the people, made up statistic, by the way, don't ask for a citing on that, that's where 99% of the people that we deal with on a daily basis are going to find themselves. Whether it's at work, whether it's in the grocery store, whether it's in the shopping center, whether it's home with our families, most people spend the majority of their life in a state of calm. Think about how you interact with them. Think about both outside the workplace, but more specifically, think about inside the workplace. Right? When that person is calm and non-threatening, they present to us in a calm manner. They don't seem agitated. They're not upset with anything. They're not angry. They're not threatening. Their presence is certainly not threatening to us. Think of that patient who's called the call light. Think of that person in their home who's called 911. They're just another person functioning in society. As I used to always say, they're a nice enough person, I'll share my room oxygen with them. They are no threat to us. Think of that person. Again, you're in the hospital setting, they ring their call light, you walk into the room. Hi, Mrs. Taylor, how can I help you? Right? Present in a calm manner, they're not agitated, they're not threatening. They've got a very simple request. Think of your response. First of all, you respect that person's dignity. You actively listen to their needs, you actively listen to their concerns, you demonstrate compassion, you demonstrate caring for them, you focus on their needs, and you build that relationship with them. Now, I've never visited most of your facilities. We've done some work in Michigan hospitals, but I probably never visited most of yours. But I know that's how you act when you walk into that patient's room, because I know my industry, and I've been in this industry for 40 years now, and I know how healthcare professionals are, and I know no matter how frustrated we get, no matter how short-staffed we are, I know the face that we put on. Dan talked about your professional face. I know the face you put on when you walk into that patient's room or when you go in to deal with that family. So, most of the people that we deal with, think about it outside the workplace. You see somebody, you and I run into each other tonight at the grocery store after work on our way to our respective homes. I don't know you, but I say hello to you and you say hello to me and we move on. We just had a very meaningless moment, but your presence was no threat to me. My presence was no threat to you. I said hello to you. I respected you. You said hello. You respected me, and we moved on with our lives. That's calm and non-threatening behavior. That's normal everyday life for the most part. And I'll talk about AIDIT here in a minute. Okay, I'll talk about it now. AIDIT is a customer service program. We didn't have this in the original program, but one of our clients added it, and one of the things we give our clients flexibility, because we know all of you have different customer service programs. When I was working in the hospital, we used Disney's Catch a Shooting Star program, and STAR was the acronym for safety, teamwork, something with an A, I don't remember. It's been a long time since I was in the hospital setting of my own hospital, and R was respect. But there's different programs out there, and we let hospitals use our program and bring their customer service program in. So we saw the AIDIT one used at a client hospital. I think it might have been over in Fort Wayne, Indiana, and we liked it. Acknowledge the person, introduce yourself, explain the duration, keep in touch, keep them appraised of waiting times, keep them apprised of how long before we get lab results, x-ray results, whatever the wait might be. Advise what you're doing. Don't just go in and start doing things. This is every day for us. This is not every day for them. Talk to them and just make them part of the process, even though they are the recipient of what you're probably going in to do. And I just had knee surgery this past Monday, and the care I received, and granted it was the hospital I had been at for 20 years, but the care I received was just fantastic. But one of the things I couldn't help but notice that every time they were going to do something, even just something from as simple as starting the IV, they'd tell me what they were going to do, and I knew it like as well as I knew my own name, but they still explained everything they were going to do to me, and it put me at ease as a patient. They let me know when they were going to give me a relaxant before they wheeled me into the OR, and everything just seemed to fall into place. And at the end, thank the person and be sincere in that thank you. Remember that last bullet point a minute ago? I'm not going to backtrack it because I wipe all these out one at a time, but it said build that rapport. Dan talked about honesty. Once you start to build a rapport and it's based on honesty and respect, you've got a good relationship with that patient for the duration of the attendance. And the AIDIT program, and we agree with this, it's a useful tool in keeping the person at the calm level. Now, you are going to deal with patients who are going to go, or people, it can be family members, who are going to go to the second level. We call this verbally agitated. Verbally agitated is a level in the continuum that every one of us have been at. Every one of us, and I always say, verbally agitated is a good person having a bad day. All of us have been there, gang. All of us have slammed the door harder than we needed to slam the door. We've kicked the tire. We've said the words we probably shouldn't have said in public. We've all been there. And that's what a verbally agitated person is. It's a good person having a bad day. They're upset about something. They're not mad at you. And we're going to come back to that here in just a minute. They're not mad at you. They're upset about something. They may be mad because They got stopped by a train today and they were 10 minutes late for work, and now they're worrying that they're going to get written up. They may be mad because they've been waiting for a half hour on lab tests that they were told maybe would be back an hour ago. They're upset about something, but they're not upset at you, but they're expressing their anger about something. And this is one of the first things we look at. Is the anger directed at any specific person or object? We always say look for directed and non-directed anger. This is non-directed anger, and non-directed anger is no threat to you. If you handle it properly, and I'm going to put emphasis on that, if you handle it properly, non-directed anger is no threat to you. They're venting, but they're not directing their anger at you. They're not saying, I'm going to get you, I'm going to hurt you, I'm going to attack you, I'm going to assault you. The person is no threat to you. And how we want to handle that, well, Dan doesn't like it when I call it this, but I call it the magic art of shut up. Just be quiet. Let them vent. Let them get, the people are just like a champagne bottle. You take a champagne bottle, it'll sit there forever. But if you shake it up and the pressure builds inside, at some point the pressure is going to build up enough inside, it's going to blow its top and the pressure is going to vent out. You don't have to do anything to get the pressure out. It'll let its own pressure out. And once the pressure's out, all that's left is a champagne bottle. And that's how people are too. Every one of us have had the pressure inside of us build up. We pop our top, we spew our venom. And when it's over, it's over. It's over. And then we start the humbling process of apologizing. Okay, actively listen to the person. They don't need you telling them. They need you listening to them. Demonstrate respect. As I said, this is a good person having a bad day. All right. At the end of this event, we don't want them to feel like you're looking down at them. We don't want them to feel that they were being judged by you. We don't want them to feel like you were trying to pick a fight with them. We want them to feel like they were upset, you recognize that, and you let them vent the pressure out. You're going to look like a genius. And all you've really done is just stay quiet and let them vent. Acknowledge their feelings. You can justify their feelings if you agree with them. Don't get into an argument or anything like that. Let them have their say. This is their time to speak. Support that person's dignity. If this is truly a good person having a bad day or a bad moment, let them walk out the door feeling okay about themselves. Let them walk out the door knowing that they are important to you, whether they're an employee, a coworker, a patient, a family member, whatever. And this is stealing a page of the old Stephen Covey book, The 1 Minute Manager, where he said, you end every minute with a positive reinforcement. You end every moment of truth with a positive reinforcement. And this one is no different. You want them to leave the time with you having vented their pressure, having been respected, and knowing that they've got your support, even if you don't agree, knowing that they've got your support and you're going to help them. And this is certainly one where you want to avoid telling them what to do. Nobody wants to be told what to do. But this is especially true because this person is venting their anger. They're not asking for advice or direction. They just need somebody to be quiet, listen to them, let the pressure out of their champagne bottle, and move on. Now, that being said, the person may continue to vent their pressure, and they may transition to the third phase, which we call verbally hostile. Now, verbally hostile is probably, in my opinion, and Dan may agree, disagree, in my opinion, from my experiences, verbally hostile is probably the most difficult of the steps in the continuum to recognize. And the reason I say it that way is because the behaviors that the person is exhibiting are almost identical to what we just talked about when we talked about verbally agitated. But in this case, their observable behavior, very similar, as I said, but this is the person who is oblivious to efforts to calm him. This is the person you're looking at him and you're quietly asking yourself, how much champagne does this bottle really hold? How much pressure is really built up in here? If you're starting to question this person is going on and on and on about something that doesn't seem that important, they've probably made the transition. The other thing that I always watch for, though, is I watch for the addition of emotion. Have you ever talked to somebody, and I'm sure you have as healthcare professionals, but you've been talking to them and they're getting so worked up that you start seeing their eyes welling up with tears. You start hearing their voice cracking. and it starts to resonate a little bit in their voice. When you add emotion to agitation, the end result is they're verbally hostile. The beautiful thing is that first bullet point, their behaviors are very similar to being verbally agitated. When I talked about verbally agitated, I talked about they are not directing the anger at you. It's non-directed anger. And this is the same thing. When they're verbally agitated and when they're verbally hostile, you are not in harm's way because they are not directing the anger at you. They're upset still about something. Your response, well, this is the first one where we need to realize that how we handle it can start to dictate what direction this goes. I want you to be very aware of your body language. We talk about, and when we do this program live, we would teach you what we call an interview stance. What I'd like you to do now, and clinicians in the room will have no trouble with this, think of the anatomic position. I'm standing, my feet are shoulder width apart on a straight line, my hands are at my side, palmar aspects facing forward. That's the anatomical position. The interview position, all I want you to do now is imagine bringing your hands up from your side and just putting them in front of your chest. So you're standing there with your hands in front of you. You're not making a fist. There's nothing threatening about your stance. Your hands are in front of you. We call that the interview stance. It's very easy to talk to somebody. Your body language is not conveying a threat. Your feet are still on a straight line. You're not in a challenging or threatening position, but you're keeping your hands up in front of you for a couple of reasons. Number one, you've got the ability to protect yourself if things change in a hurry. Number two, you're also conveying to them that you are no threat to them. You have no weapons or anything you're going to use to harm them, and you can talk to them and not be a threat to them. So your body language at this point, remember this person may now start to be getting a little bit emotional, getting pretty worked up. So your body language starts to have a lot to do with how they perceive this is going to go. We always teach here we want to respect the personal zone. Now, when we do the full program and we get into the hands-on escapes from grabs and holds and proper application use of restraint devices, we teach one type of personal zone. When I teach a personal zone here, I'm talking about the distance between two people. You know, all of us have that space between us that we don't like other people to invade. Watch the next time you're introduced to somebody. You'll come up, you'll be introduced to somebody, you'll shake hands, then subconsciously one or both of you are going to take a step back. You're going to establish non-verbally your personal zone. None of us like to have other people invading our zone, and when you do, when somebody invades our personal space, we either like to take a step back and try to politely and non-verbally tell them don't invade, or we may take other action and ask them to take a step back if we're feeling threatened. I can remember years ago I was in a traffic accident and I was in the hospital, and the one particular nurse, and I had great nursing care. I was in the hospital for about 5 days. There was a motorcycle crash. I was in the hospital for about 5 days and I had fantastic nursing care. But there was one nurse on the midnight shift, and she would always come in about 2:30 in the morning to wake me up to see how I was sleeping. And when she would come in, she was fantastic, but she would always position herself where she was laying I was laying in the bed, she's standing next to me, her hips literally touching the bed right near my head. And I just felt like she was just constantly invading my personal space. Lying in a hospital bed with side bed rails up at that point in time, I felt kind of intimidated. And we'll talk more about that later. But at the same time, if she would have just taken a step back, I could still see her, we could still communicate, just give me my space. And that's what most people want, is respect their personal zones. Don't invade their space. They're upset, they're emotional, they're angry. They don't want you pressing into their personal space. Give them their distance, please. Again, allow them to continue venting the anger. Be quiet, let them vent, acknowledge their feelings, acknowledge their positions on things. Don't get into an argument. Somebody asked a question about arguing. It takes two people to argue. All right, you can acknowledge, but you don't have to argue. Now, this is a person, remember on the last slide I said, don't give them orders. This is a person we may need to prod them a little bit. You know, they may be in an environment where we're out in the public. We may be at a nurse's station. We may be in a waiting room, a family waiting room. We may be in a quiet room somewhere along them, and we want to take them somewhere and talk to them a little. Well, we can tell them, go in my office and we'll talk. None of us want to be told what to do. But at the same time, we can't have this conversation out here in front of everybody, so we have to get somewhere that's a little bit farther away. When we were working years ago, excuse me, when we were working with Dr. Moran putting this program together, we started asking ourselves, who do we know that's really good at getting people to do what they don't want to do, but almost making them feel like it's their idea? And as we talked about it, we realized that that's the job of a salesman. And so we started thinking to ourselves, okay, what kind of salesman? Well, if you think about it, every salesperson wants the customer that walks through the door to do what they want them to do. But I think the one industry we all think about when we think that way is car salesmen. And we were very fortunate that we had a couple of friends who were in car sales. And so we went to them and we asked them specifically, how do you do it? How do you take that person? And think about, guys, the last time you walked in the car showroom, you're almost walking in a defensive stance. You got your fists up, you're ready, because the minute you walk in, the vultures are on you. And so we asked, how people are walking in the showroom with that mindset. How do you turn their mindset around and at the end of the day, get them to sign on the dotted line to buy the car? And they said a couple of things. They said, number one, we always try to get them to agree with us, because the more you ask a person questions and they agree with you, the more likely they are to comply with your requests at the end of the day. And they also try to use words that end with N''T. Can't you, won't you, don't you, wouldn't you, shouldn't you, couldn't you? Again, questions that they're going to answer yes, but we're using those N''T words to lead them to the answer that we're looking for. Right? So if I'm sitting with Dan and I'm a caregiver and Dan's a family member and he's out at the nurse's station getting a little bit loud and maybe a little bit obnoxious with his behavior, we're staying at the nurse's station, everybody in their rooms and every family member can hear him, and I don't need that because that's just going to influence other people. So I need to get Dan to go in my office and we're going to talk about this. So instead of saying, Dan, go to my office and we'll talk about this, and he's going to say, take a long walk on a shore pier, Steve. I'm not going to your office. I can talk right here. You don't tell me what to do. Guys, how about instead I change my approach and I say, Dan, I totally understand how upset you are. This is probably not the best place to talk. We can go in my office and talk about this, can't we? What's he going to say? No, I want to stay out here and make a fool of myself. Those N''T words. I'm letting him make the decision, but I'm trying to lead him to the right decision. And that's what de-escalation is all about, guys. Trying to lead the person you're dealing with, that you're trying to de-escalate, trying to let them see what the right decision is and trying to help them make the right decision. And those N''T words are your clue in helping to guide them to the right places. Now, I know for a lot of you, this is something new. I do it a lot. Dan does it a lot. We use this all the time. We've been training people in and out for, I don't know how many years. I used it in my practice as a paramedic for years. And I'll tell you the truth, it's not 100% fail-proof. We're talking human behavior. Nothing here is foolproof. So, in dealing with that, don't think that just because those guys from Illinois said it will work, it won't. It may not, guys. Everybody's different. But I would like to encourage you to practice it, try it a little bit, and get acclimated to the ways of doing it. As a matter of fact, I'll give you a homework assignment. Let's try it tonight. When you get home from work tonight, I want you to look at your significant other, your spouse, whoever it might be, and say, I had a really long day today. I had to sit in a 3-hour webinar, and you know how hard those are to sit in. The last thing I feel like doing tonight is making dinner. We can go out for dinner tonight, can't we? Don't tell them who tell you that trick, but see how it works. See if it gets you a dinner out. I do that jokingly, but at the same time, guys, I really encourage you to learn to use this technique because it's very effective, right? And continue to make collaborative statements with the person. Ask them, what can I do to help fix this for you? Dan, I can't make the lab results come back any quicker, and I'm sorry they're taking so long. What can I do to help you out? I've called the lab twice. They know we're waiting on them. They're trying to make them a stat. What can I do to help you out in the meantime? And you may be shocked by his response. He may say nothing. I just wanted to know somebody was looking into it. But look for ways to make collaborative statement. Make it a we thing, not a me thing. And a lot of times when we're talking with people who are verbally hostile, They'll try to use past experiences with you to bring up the present. Every time I come in this hospital, it's the same darn thing. A year ago, I had my mom in here and you treated her the exact same. Well, Steve, I'm sorry that you had bad experiences in the past. I can't do anything about that. But let's focus on this admission and let's focus on what's going on now and see if we can't make things better for you. You know, right there, my simple response is neutralized past things. And everybody's got a horror story to tell. So, you know, the more we can do to keep it specific to the here and now, the more successful we're going to be. I really, you know, there's things, there's nothing on here I didn't just talk about with the end apostrophe T words. Again, I encourage you guys, try them. They're effective. Nothing's 100% effective, but they will work and they will help you lead the horse to water, if you will. Now, do you want to jump in? Okay. All right. Again, as I look back at those three, calm, verbally agitated, verbally hostile, the commonality between all of them was the anger was non-directed. When we start to get to verbally threatening, now it starts to change. The anger starts to become focused. They start to direct their anger. Okay, this is the person who they start to say, Steve, you listen to me. And they're calling me by name. They're pointing their finger at me. They're calling me you. I can tell who they're mad at. I can tell who they're directing their anger at. I can tell if they become physical, who they're going to turn their physical aggression at. This is the person that may start making demands for actions. And along with that, they'll tell you the consequences if their demands aren't met. You're going to get those lab results back in the next 10 minutes, or I'm going to, whatever the case may be. All right, so again, when you start hearing them calling you by name, when you start seeing them pointing fingers at you, when you start hear them addressing you, and they may start, again, these demands for actions, telling you what's going to happen and telling you what's going to happen if that's not the case. You need to realize they've just shifted from non-directed anger over to directed anger, and you are starting to find yourself in harm's way, or hell's way, whichever way you want to look at it. Your response in this game, first of all, if you have some type of code team, you'll see this is in code green. Years ago, or in green. Years ago, we used to work in the hospital, and theirs was the code green. So we put this in green, and we've always left it in green, because if you've got a code team, now's the time to mobilize them, because you wait any later than this, it may be too late. We want you to maintain eye contact with these people. Don't get into a stare down contact, but watch their eyes, because their eyes may tell you what their mind is thinking, what their next move may be. You need to provide honest options, and Dan talked about honesty earlier, but boy, it's never been more true than it is right now. This is not a place for you to really be in there alone. We would want you to use the buddy system, and Dan's going to talk about that after our next break. We're going to utilize the buddy system. We want you to have help in there with you at this point, because when they're starting to direct their anger, they may reach that top rung on the ladder at any point in time. Again, triangular de-escalation, we're going to spend more time with that in a few minutes. And at this point, we really need to be aware of cornering. Cornering means to trap. And I'm going to skip this slide because Dan will talk about the buddy system. Well, no, I'm not. This is where Dan talked about, he's changed the program, and Steve may not see all the changes. All right, let's talk real quickly about the buddy. You want to talk about the buddy system for a couple minutes?
I'll be happy to talk about the buddy system.
Remind me, folks, slap my son.
So when we're responding to an incident that has the possibility of becoming violent, we don't want to go one-on-one, like Steve was saying. We don't need every single person in their department responding to it either. A good team of at least 2 people, or I always prefer 3, but sometimes, especially on midnights or late at night, it is difficult to have 3 people available. But a team of 2 to 3 people performing a talk down is all we need. If it gets to a point where we are going to need physical intervention, we want to have 5 or 6 people to help us put restraints on, but we don't want more than that. So we're going to discuss right now doing the talk down with a 3-person team. So you'll notice we have our red face guy, and that's Steve right now because he didn't realize I changed the PowerPoint on him. And we have one person up front at the top of the triangle who's going to be talking to him. That'll be the person who is trying to de-escalate our aggressive person. He's the only person talking. Everybody else is in the background. They're sitting silently. If we have a restraint team already there, they're not even in view of the aggressor. They're nearby. They're getting the restraints ready. They're getting a plan ready. but the 3 people are the only people in the view of the aggressor. The 2 people in back are watching. They're making sure that the person talking is not getting too worked up. They're not getting aggressive themselves. They're not missing different signs that are coming out. If this person becomes violent, they're here to step in right away. Also, if they have a need, they can switch out with the person in front. If that person is not being effective, and it happens, there's times when we cannot talk somebody down for whatever reason. The person in the back can use a code word. I always like the one, is it getting hot in here? When I hear hot, I know that it's time for us to switch out, because that's them telling me that, hey, Dan, you're getting hot. So I'm going to back out and let that other person come up. And now she's in charge of the talk down. And depending on where I'm at on the ladder, I may even step off stage and get out of the way and calm myself down, because I'm not going to be any good if I'm so mad that I can't keep my mouth quiet. All right. You want to?
Thank you. Now you know that that's one part you won't be covering later on, and I do appreciate that. Dan used the word, you're going to step off stage, and I like that term. That's a term that we've used for a long time, and that goes back to my hospital days when we were using the Disney's Catch a Shooting Star customer relations program, because one of the things Disney always taught was, you're the face of the organization. You represent what we stand for, and we all know that that's true in our facilities and our organizations as well. And they train every employee of Disney that the workplace is a stage and you're representing the company. And you'll never see that Disney employee walking around with a Mickey Mouse costume on, but with the head off. That's not what it's for. No matter where in the park they are, they're on stage. And that's really the term we use, because you truly are on stage whenever we're in the hospital, whenever we're in the field, whenever we're in the facilities, whatever the case may be. We are representing the company, and we are representing the image. So we are on stage. So continuing on, we started to talk for a minute. We said, don't corner. Corner means to trap. And when we talk about cornering, we use the acronym CAPE, C-A-P-E. The first type of cornering is contact cornering. That's where I go up and I put my hands on person. You know, they may be sitting in the desk or sitting in a chair, and I get up and I walk over, and I might put my hand on their shoulder. I may grab them by the upper arm. What right do I have to touch that person? I have no right at all, right? No right at all to put my hands on another person. And just because somebody is a patient, you know, we are a very touchy-feely industry in healthcare. I always tell the story, when I was working in the hospital, we had an incident in the ER one time where a family was called in. Their 16-year-old daughter was involved in a motor vehicle accident, and I was in a Catholic hospital. The 16-year-old daughter involved in a motor vehicle crash, did not survive the accident. Mom and dad are put into the family room adjacent to the ER. The doctor comes in to tell this family the terrible news, and as our protocol, we had pastoral care there, where we had Sister Elsie with us, and she was a little German lady, not 5 foot tall, and when they told the family the terrible news, of course, the mom and dad's grief was overwhelming. And Sister Elsie put her arm around the dad to try to console him, and he literally pushed her, knocked her out of the chair and onto her can on the floor. Not to be violent, but he did not want to be touched. Right? Hands off. We don't need to touch people. And a lot of times people will react that way when you touch them when they don't want to be touched. So don't contact the corner. Keep your hands to yourself. Don't contact corner the person. Keep your hands to yourself. The second one is angular cornering. Angular cornering is when the person might be sitting in a chair and you are moving around and they're chasing you all over the place with their eyes. You might be pacing the room, moving all four. You know, their eyes almost look like they're at a tennis match or something. Guys, stay in one place. Make eye contact with the person. Talk directly to them. Psychological cornering, and I kind of alluded to this one a little bit ago. When I was in the hospital bed and the nurse is standing over me, I felt so intimidated by her presence, the fact that she was so close to the bed and that she had to be so close, standing over my head, looking down at me. I felt trapped in my own hospital bed as a patient. All she had to do, and she was one of these contact touchy-feely nurses too. She didn't mean anything wrong by it, but the whole time she was talking to me, my arms were at my side, and she would put her both hands on my forearm and talk to me. So I'm feeling psychologically cornered. You know, I'm intimidated laying in this bed as she's standing, towering over me. At the same time, I'm feeling contact cornered because she's got her hands on my arm. She wasn't holding me down. There was no pressure, but it still gave me that illusion that I couldn't move my arm if I wanted to. All of these can cause a person to, you put your hands on me inappropriately or on anybody, they may push you back to break the contact. You're in the wrong. There you have the legal right to protect themselves. And the last one is exit cornering, CAPE, exit cornering. Exit cornering, we do two ways. Either we position ourselves in front of the door, which gives the person the nonverbal message, you can't leave here unless you go through me or over me, or we allow the person to get between us and the door, where the only way for us to get out is through them or over them. So we always need to be aware in terms of the geographics of the room, where we are in relationship to the door. We never want to block an open door because that challenges them to get through it. It's a nonverbal challenge to them. But we also want to never be in a position where they are between us and the door, where we can't get out if we need to get the help or get to safety in a quick matter. Now, continuing up the ladder, we get to the fifth step. We know they're already at the mode now. They've gotten past non-directed, they're at directed anger. They become physically threatening. They may start to take a chance that suggests violence. They may start to look around the room. That's where I said earlier, watch their eyes. They may start looking around the rooms for what we call weapons of opportunities, things they are looking at that they could use as a weapon against you. They may make a bluff move against you. They want to see how prepared you are. They may just make a twitch at you or something to see if you react by curling up in a ball, or if you take a defensive stance yourself and stay calm. They want to see how prepared you are. Guys, you need to recognize this is the critical point. The next step in the continuum is that top step where that big sticker is that we talked about. Don't stand here, you're going to fall and get hurt, right? This is the critical point of de-escalation. Earlier, I wanted you in the interview stance. Now I want you in a defensive posture. You're still in that interview stance. I don't want you making a fist. I don't want you inviting them to fight or anything like that. What I do want you to do, though, you're either right-handed or left-handed. If you're right-handed, your right side is your strong side. If you're left-handed, your left side is your strong side. I want you to take your strong side foot, still keep your hands open in front of your chest, but I want you to drop your strong side foot back about 1/2 to 3/4 steps length and turn your strong side foot out to about a 45-degree angle. What you've done now is you've taken your weight off of that center axis and you've balanced your weight on both feet. So it's not going to be as easy for them to push you and knock you over. You don't want to be on the bottom of a floor fight. So we want to make sure you're a fire hydrant. They can't push you over, and that's all that defensive stance. It's not using your hands at all. It's all in your feet and leg positions. We want you looking for strong side, weak side indicators. We want you to position yourself on that person's weak side. With the exception of trained martial artists, most everybody has a strong side or weak side. I want to give myself every advantage with you being this close to the top rung of the ladder. I want to be on your weak side where you have to use your less strength side, your less coordinated side to try to aggress against me. I want to give myself every advantage to protect myself if I have to.
We'll look at those on the next slide.
All right, and we're going to look at the weak side, strong side, weak side indicators in a minute. There's some little tricks you can use. And again, you're one step away from the top step. I want you to be prepared for a physical attack. I want you thinking, how am I going to protect myself? Now, when we talk about strong side, weak side indicators, you'll notice one commonality these 4 bullet points have is each of them starts with the word most. Again, this is human behavior. Nothing is guaranteed, but we do know most people carry their keys, phones, bags, stuff like that with their strong hand. It's a protection mechanism. We know that most people will use their strong hand when making hand-to-hand gestures. They'll wave at you with their strong hand. Most people wear their watch or fitness device or their Apple Watch or whatever the case may be on the weak side. Think about these. Look at yourself as you're looking at these. And most people stand with their weak side facing forward. All right, if I'm standing, just like I did in my defensive stance a minute ago, I drop my strong side back, I leave my weak side foot forward. All right, so my weak side is facing forward. You should be able to look at a person and tell, and I usually use, to me, the most reliable one is always that one about the watch or the fitness device, whatever, on the weak hand. All right, that seems to be more reliable with both men and women. If you're not sure though, guys, assume that they are right-handed and their left side is their weak side. Line up on the left side. 93% of society is right-handed, 93% of society, the weak side is the left side. good odds that you're going to be correct if you're not sure and you line up on the left side. But you want to position so that their left shoulder is across from your left shoulder, so that they've got to use their weak side to aggress against you physically. Their weaker side, their less strengthened side, their less coordinated side. And when we get to that point of the person becoming physically violent, if they go all the way up, you know, again, I should have mentioned, I'm cognizant of time here, most people don't get beyond verbally hostile. Most people, it never gets to verbally threatening where it becomes directed anger. Most people stop at verbally hostile because most of the time we're pretty effective using these de-escalation techniques. But if they become physically violent, they physically will attack you in some form. Your response is you either change to a self-defense mode or a self-survival mode. You stop trying to de-escalate the person and you try to escape. Get out of that environment. You don't want to stay and fight. You want to escape. I don't care how big or how bad you are, you need to get out of the environment. You know, we use the terms so interchangeably, self-defense and patient control, but they mean two very separate things. Self-defense involves any and all means of self-protection. The force has to be reasonable and necessary. The tactics aid in the escape of the individual from an attacker without regard for the attacker's well-being. And these are used only in emergency situations to protect the provider from harm or injury. You know, there's another one, though, from a risk manager's point of view that we have to include, and that's the reasonable person standard. Your actions have to be that of a reasonable person, right? And your actions have to be that of another healthcare professional in the same situation. So, you know, I may be able to protect myself, get to a door and escape, and that's what I want to do. I get the person down and I reach up on the desk, grab a stapler and start gouging them. I've exceeded the reasonable use of force. Patient control, on the other hand, when I'm dealing with patients, are tactics that are used to maximize patient safety while minimizing. You know, we can't lose focus of that patient's rights. They have the right to remain safe from harm and injury, including that inflicted by healthcare professionals, even under the most dire circumstances. We have that professional responsibility to protect and defend. And I don't have time to talk about case law right now, but I could talk about multiple cases in which patients have been physically injured in the hospital, even though the patient was acting out. The techniques that were used by the healthcare professional to manage, to try to control the patient were so inappropriate that it caused injury to the person. It exacerbated the patient's condition and necessitated further and more aggressive medical intervention and resulted in some pretty serious litigation against the healthcare professionals. So, you know, we have to be sensitive to that patient bill of rights. It is so critical. There is nothing in there that says that if the patient's acting out, you can use excessive force. You can't. And I just mentioned these, so we'll keep going.
All right.
So I'm going to turn it back over to Dan. He's going to talk about some different de-escalants that we can apply that tie in with what he and I have talked about up to this point.
Yes, at this point, we're going to be starting almost a review process. So we're going to go through these a little bit quicker. I know it's almost 1 o'clock or maybe different where you're at, but we will get done relatively quickly here. I know we're going to go over a few minutes, but we're going to also give you time to answer questions, so we're not going to leave you hanging. So the 10 de-escalation tips to apply. First one, commit to an outcome. We're going to restore calm. We're going to do everything we can to help our patients, regardless of what side of the house we're on. We're going to do everything what's best for them, and that's something we have to commit to. Pay attention. There's a lot of times where people say something, and if we're really listening, we can hear what they're saying, we can answer their questions, and we can take care of them, but we're not listening to them. We're waiting for them to stop talking so we can talk. And if we listen close enough, they will tell us what they need. Know the aggression continuum. This isn't something that you're going to be able to remember a month from now if you've never looked at it again. During the height of COVID, we were shut down for almost a year, and we didn't look at these a lot, but it took a little bit of time before we got comfortable teaching again, because if we don't look at this, it becomes something that we forget. So we have to remember this ladder. We have to look at it. We have to train on it. Assess the cause. What caused this person to become aggressive? Was it something that we said? Was it something that we did? Is it what happened prior to them coming into the building? Okay. But what caused them to get angry? Avoid ego battles. So often it's, we're going to do it this way because I said so. And we don't want to get into that battle with them. When we go into ego battles, we got to have a winner, we have to have a loser. And that's not where we want to be here. Monitor the status, monitor your status. It's possible for your champagne bottle to get shaken up. And if that happens, you need to get out of there and calm yourself down. Monitor the environment. It's not uncommon for somebody to escalate to a point where people are paying attention to them while somebody in the background is doing something else. That's a good part of having your team ready, because everybody there is watching. We're not just focusing on the aggressor, but we're focusing on what's going on behind them as well. Offer honest options and choices. They get to choose, but we want to give them the choice. What are their possibilities? There may be no good answer, but let them make their own choice. And avoid cornering. Steve talked about CAPE. Okay. And we talked about leadership. The person who is talking is the person that is in charge. Everybody else needs to stand back and be quiet. And if somebody else is going to take charge, we need to get out of their way and allow them to do the talking. All right. So again, some review points. Watch for some sudden movements towards us. They want to judge what our reaction is going to be. And if they make a bluff move and we freeze or we cower or we flinch, we tell them that they have the power. Watch for tightening of small and large muscle groups. You see them clenching their fist. You see them doing that. They start smacking their chest. That's telling us that they're starting to get angry. You see them shrugging their shoulders. They're getting their blood flowing. They're loosening up their muscles. It's ready to go. Twitching facial muscles is indicative of somebody who's becoming stressed out. 18 years ago when I got on the fire service, or 20 years ago rather, I had a lieutenant who was a young guy and he had a young family at home, and his family would come by and visit us at the firehouse. And being a younger guy, I'd like to play with the kids and get the kids all hyper. We'd run through and play with the rigs and that kind of thing. And as his kids got hyper, his wife's eyes started twitching more and more because she's so afraid that one of her kids would get hurt playing on the apparatus. And well, today now, 20 years later, it's my kids running around. It's my eye twitching. But when we see that, we know that person is getting stressed. Darting eye movement. Are they scanning around looking for potential weapons? There's a lot of weapons in our work areas. It may be something as simple as a blood pressure cuff or a stethoscope. Fixed staring tells you if they become violent, who are they going to become violent towards? It's going to be the person they're staring at. Glancing for weapons, think of all the different weapons that you have. All right, shifting imbalances. If they're standing in what looks like an interview stance and then they all of a sudden go into a defensive stance, that's a big indicator. We need to be observant of that. Raise pitch, increase volume. You ever notice when you get mad, you start talking, and the louder you talk, the louder the other person talks. And it gets to a point where you're not even talking anymore, you're just screaming at each other. It's increasing your aggression. Okay, so as they talk louder, we need to actually talk slower and quieter. Changing in stances. If they're seated and they stand up, we need to do the same, because that's a big clue that somebody is becoming aggressive. And then watch their breathing rate. If it increases, they're trying to get more oxygen into their bloodstream. It's sometimes a nonverbal clue that they're going to become violent. Don't give orders instead of choices. Again, Steve said it earlier. Nobody likes to be told what to do. Don't project that I don't give a darn attitude. It's 2 o'clock in the morning. I'm tired. I ran 13 calls all day, and this is the last thing I want to do. So why are you bothering me again? If you don't care, they're going to do something to make you care. Okay? Don't stare at the person. Keep eye contact, but we don't want to do staring contests. Don't lie to the individual or threaten them. I've heard that a lot from a lot of different colleagues. If you don't do what I say, this is what's going to happen to you. If you don't get on the cot right now, I'm going to tie you down. I'm going to handcuff you to the cot. That's not the way to get them to cooperate with us. Don't argue with them. Remember, like Steve said, it takes two people to argue. It's our bat, our ball, our rules. We need to allow them to vent. We need to hear what they're going to say, but at the end, it's our way. Don't turn your back on that person. We may think we did a great job doing a talk down, and we turn around, and as soon as we turn around, there is no way for us to see what's going to happen. It gives them the perfect opportunity. And don't become emotional. It's possible to get intimidated by patients. It's possible to get angry. It's possible to even get sad from what they're telling us. Right? We need to keep that in check, though. Right? And don't corner them. We've talked about that a lot, so I'm going to move on. What we do want to do is monitor our own status. Right? We see ourselves getting angry. We see ourselves getting worked up. It's time to get out. Demonstrate self-confidence. We have a team of people here that's going to help us. If we can show that we're competent, we may be able to talk this person down. But if we're so scared that we're stuttering and we're flinching and we're playing with our fingers or keeping our hands in our pockets, it shows them that they have the power. Stay calm and relaxed. Again, like I said, it's your bat, your ball, your rules. We just want them happy to follow them. Keep your pitch and volume down. We talked about that. The louder they talk, the quieter we should talk. Give them honest options. I'm not going to talk about that anymore. We've talked about that a lot. Allow that person to make the choice. Allow the individual to save their self-esteem. They're in a bad situation. They're having a bad day. We're going to see these people again. We're going to work with them again. We don't want them to see us and be embarrassed of the way that they acted. Maintain a safe personal distance, at least 1 arm's length. Position yourself on that individual's weak side. We talked about the strong side, weak side indicators. Okay. If you're unsure, 95% of society is still right-handed, so line up on their left side and take your time. This is one of the things I hear a lot. I hear it at my fire department. I hear it at hospitals that we visit. We're short-staffed. We don't have time to do a 20-minute talk down. We don't have time to spend going in there and talking to this person every 5 minutes when we could just tie them down. But if you don't have time to give a good de-escalation, how do you have time to do everything else that comes with a takedown or putting that person to restraints? It's a lot more time consuming on the back end. If you're involved in an incident, first thing you need to do is make sure anybody who is involved in the incident has the appropriate medical necessities taken care of. Right? There's going to be ouchies and boo-boos and scrapes and bruises, and we need to make sure that people aren't injured. Okay? Report the incident to your supervisor. Make sure it's all documented. Make sure they know what's happened. Complete your violent incident report form and document everything. The better documentation you can give, the more protected you will be if something happens and you go and it goes to court or there's a hearing about it based off of complaints or whatever the case may be. The better you can do at documenting it, the safer you're going to be in the long run. And if you have an incident, talk about it. Okay? Talk about your feelings. Talk about what good, what went bad. If it's a big incident, if it's a small incident, it doesn't matter. Watch for signs for PTSD. It's real, and it's causing us to lose a lot of good workers because people don't want to talk about it. And we want to continue to care for these people that are having the hard time. We see a lot of ugly. It may be a very minor incident that triggers memories from a larger incident and that we never knew was a problem. And if we don't get it taken care of, it's going to haunt them forever. Okay? Utilize your critical incident teams and your crisis intervention teams. These guys can come in after an incident and help people talk about it. If you have EAP programs, make sure your employees know about it. We go to so many places, we talk about EAP and they go, what does EAP mean?
That's terrible in this day and age.
It's so helpful if people are aware that it's there, but it's absolutely useless if we don't push it. And there's a lot of good programs out there that are going underutilized because they don't know it's there. Okay. And then critique each session for quality improvement. Talk about the good, talk about the bad. What can we learn? We can learn from everything. Okay, folks, thank you very much. We are here. If you have questions, utilize my email address. Not sure where the G Nixon came from. That should have been gone. We changed that last week. So utilize our email address or my email address if you have other questions that we don't get to talk about today. We're going to stay on for a few more minutes and answer any questions that may come up. Our office number, 815-933-5977, is staffed Monday through Friday, 8 a.m. Central Time till 5 p.m. Our crisis line, if something bad happens in your organization and you need help, call us. That number is staffed 24 hours a day, 7 days a week. My cell phone number is on me 24 hours a day, 7 days a week. If I'm not on a client side or on an ambulance or fire call, I will answer that phone. And email as always works just as well as also. So at this.
Dan, we do have one question asking for advice for back of ambulance when you are alone with psych transfers.
Well, using the techniques that we've given today, try to talk to the person, give them as much, try to make them feel as comfortable as possible because they're having a difficult time as well. If they're not in restraints, do everything you can to keep them calm while you're talking to them, talk in a low voice, be very caring and empathetic to that person, and monitor their status and watch for changes because it can come quickly with a patient like that. Steve, you have anything you want to add?
I'll go back to those N apostrophe T words too. The more you can get them in agreement with you, no matter what you're talking about, the more they agree with you, the less likely they're going to be to aggress against you. So try to keep them in your side. And it sounds so easy to sit here and talk about that, but any of us who work pre-hospital have been in the back of that box when when everything seems to go to hell in a handbasket on you, and it's a lousy feeling when you know that you're trapped in those walls and you don't have a partner to help you. So thanks for a great question.
The other thing I also do is I have a predetermined code word with my partner that if he hears me say it, that means things are getting difficult and I need them to either stop or call for assistance or pull over or whatever the case may be. Yeah, I'm going to need some help.
A lot of it goes back to the, and obviously you can't do this in a virtual world, but a lot of it goes back to the physical training you've got. When you're in the back of the ambulance, the physical confrontation is a lot more dangerous, not only because there's so much stuff almost within immediate arm's reach, no matter what direction you turn, that can be used against you, but because escape is almost impossible because a lot of times you're in motion going down the road. So the physical training, physical aspect side of it, where you're trained in escaping from grabs and holds, where you're trained in, it still cracks me up. Maybe I shouldn't say cracks me up. And it worries me when I still see people, whether it's in an ambulance or in the ER, trying to control a patient from kicking, and I see them laying crossways against their knees. No, that's not the way you control somebody's behavior. It's not the way you control them physically. So making sure you get trained in proper techniques of hand-to-hand control so that the person can't hurt you is critical enough to be considered also.